Hello, everyone. You're welcome to today's 6th Lisabeth Hockey Memorial Lecture. We are going to give a couple of minutes so that everyone joins, and we shall be beginning 1 minute past. Yeah. All right. Thanks everyone for joining us today. Again, you're very welcome to today's 6th Lisabeth Hockey Lecture, which is jointly hosted by the Global Research Nurses Hub, which is part of the Global Health Network under the University of Oxford, and the International Collaboration for Community Health Nursing and Research. We have some housekeeping points that you need to pay attention to. This webinar is being recorded and will be shared on the TGHN and the ICCHNR website. To automatically translate the speech to subtitles in your chosen language, navigate to the closed caption function and select your language. Due to the number of participants, your video and microphones have been disabled. And please use the chat function to introduce yourself or to report any technical issues. Please use the Q&A function to post your questions and comments. You may do so anonymously as well. So this is the map showing where we are all coming from that are attending this lecture and those that have registered to be part of this session. So today's panel and agenda, my name is Dr. Faith Nawaji, and I'm the coordinator for the Global Research Nurses with the Global Health Network under the University of Oxford. And I'll be your chair for the session today. We'll have some opening remarks from Professor Sally Kendall, who is the director of the International Collaboration for Community Health Nursing Research. And we shall have our keynote presentation from Professor Champion Nyoni, who is the Technical Officer, Health Workforce Education and Training from the World Health Organization Africa Regional Office. We shall then move to Q&A session where all participants will be allowed to have a Q&A with our keynote speaker. We'll have closing remarks and an evaluation poll that will be projected for you to share and evaluate your experience with the session. With that said, over to you, Professor Sally Kendall.
Thank you, Faith, for that introduction. And I do have just a very few slides to start this introduction. Thank you. So we're absolutely delighted to welcome you all this morning to the 6th International Lisbeth Hockey Memorial Lecture. As Faith has said, this is in collaboration with the Global Health Network and the Global Nurses Network, Research Network. I just wanted to let you know a few words about the International Collaboration for Community Health Nursing Research. So we are a UK charity, and I'm one of the co-directors with Professor Gina Higginbottom, and we have a whole team of people behind us too on this organisation. So just to go through to our purpose. Next slide, please. So ICCHNR has a very broad global purpose, which is to support community nurses worldwide through its international network of nurse researchers, international conferences, fundraising activities, and scholarships for community healthcare nursing research in countries with emerging economies to advance and share knowledge of evidence-based practice for community healthcare nursing for the benefit of the public. Thank you. So we're here today to introduce our speaker for the 6th International Lisabeth Hockey Memorial Lecture. So Lisabeth Hockey was our founder of ICCHNR, and she was a huge inspiration both to our organisation, but to nursing research nationally and internationally. Lisbeth came to the UK in 1938 as a refugee from Austria, and she settled here having to learn English as both a nurse and a midwife, and she became a district nurse and became increasingly curious about why in nursing we do what we do, how we do what we do, and what a difference that can make to patients and communities. So Lisbeth found herself asking constant questions, which she then formulated into research questions and became one of the very first nurse researchers in the UK to publish her work in national and international books and journals. And she became a huge inspiration to many of us in community nursing with textbooks that she wrote. And I've listed one here, Care in the Balance, very much emphasizing the role of nursing in the community and the balance between the practice that nurses do and how that can improve patient outcomes and the care and the cost of that care. So she had quite an eye on the economics of healthcare as well as also on research methods, which she published quite widely on. So she became a huge inspiration to us. And I think that today, Lisbeth would be thrilled to know how much of her work we are continuing as part of her legacy and what we are achieving in terms of research across the globe. But I think she would also be quite horrified at how we are still having to fight for community nursing in name, in practice, in recognition, and for the levels of funding that we receive to do research. This is something that we are still very much in policy terms fighting for. And I think she would be proud that we are, but also quite horrified that it's still very much on the agenda. Thank you. So we set up a series of lectures in Lisbeth's honour, and we are now on our 6th lecture today, which we're very delighted and pleased to welcome Dr. Champion Nyoni to present for us today. And you will see there's been a series of others. If you want to go back and listen to any of those, they're all on the ICCHNR website. And we've had some marvellous speakers over these last lectures. Thank you. And just to emphasize some of the work that we've done many global events. Some of you may have been present at our last event in April 2025, which was a huge success, but we've done many others around the world. And it's a bringing together, a sharing of learning, knowledge, evidence-based practice, totally focused on community nursing in all its different guises around the world. And we also aim to invite, multidisciplinary aspects of that to these conferences so that we're sharing the voice of community nursing worldwide. Thank you. And another achievement that ICCHNR are very proud of is the setting up of a network of scholars, again, across many, many countries around the world. We've been able to offer funding to our scholars to both attend and present their work at our conferences and to become part of a network of scholars, which we are now in the process of developing a very strong global community of practice of scholars across the world to strengthen the ways in which the voice of community nursing research can be echoed across the globe and strengthen both practice and policy through nursing research. Thank you. And just to let you know that we are planning another conference in 2027. It's yet to be announced, but we would love to welcome you when that conference is announced. And please think about joining ICCHNR. That's our website details. And once again, thank you so much to all of you for joining us today. And of course, our huge thanks to the Global Health Network, to the Global Nursing Network, and to Dr. Nyoni for today's lecture. We are really looking forward to hearing it and to hearing your questions, your discussion at the end. Thank you so much.
Sure. We are now going to transition to Professor Champion Nyoni to take us through his lecture. Professor Champion, over to you.
Thank you very much, Faith. Please confirm if you can hear me and you can see my screen.
Yes, please, we can.
All right. I'm just going to switch my camera on for a while. My bandwidth is not good, and then I will just switch on and come back just after the lecture. This is me, and thank you for having me. So good afternoon, colleagues, friends and fellow practitioners. It is an extraordinary honor to deliver this year's Lisbeth Hockey Memorial Lecture, and to do so from an African perspective. I think this is quite an interesting and an exciting opportunity for me. I am deeply grateful for the invitation and the nomination that made this possible. As we know, Lisbeth Hockey was a pioneer in the true sense, a refugee, a nurse, a researcher, a visionary for district nursing, and one of the most influential voices in advancing community-rooted, evidence-based practice. Her work, from leading on one of the first nursing research units in the UK, just like what Prof. Sally has said, to championing district nursing, insisted on two main things. Nursing must be grounded with realities of people's lives and not confined to the walls of the hospital, and that nursing must develop others, practitioners, communities, and systems. So both these themes sit in the heart of what I'm going to present today. And as mentioned, my name is Champion Nyoni, and I currently serve as a technical officer for health workforce education and training at the WHO Regional Office for Africa. But I'm just not going to stand here as a bureaucrat or part of the WHO, but I'm just standing here as a nurse who began a journey somewhere in Zimbabwe and who's ready to share part of his career in trying to understand education, practice, community realities, and how these shape each other. And today, I just wanted to speak about what it means to light other candles in practice, in education, in research, and across systems, and what it truly costs for us to do that. Began as part of one of the early cohorts, and at the same time was resisted with equal measure. We had a few role models. We faced real hostility from those who questioned what a nursing degree meant and why it mattered. But those early years taught me two things that would later shape my scholarship. The first issue was that a curriculum is only as powerful as its alignment with real practice. And competence emerges not only from what we teach or what we are taught, but from the conditions in which people learn and work. So my first posting was in a district hospital. And this sort of sharpened this understanding. In these district hospitals, there were patients that queued for hours, where they had queries and they couldn't trust the health system. We worked in spaces where the resources were limited, and the demands on nurses were immediate, they were intense and unrelenting. So the gap between training and reality became sort of the seed of my early career research. At that time, I started to think a lot about professional identity formation, particularly within primary care, having studied and having been engaged in a degree that was very focused within hospital care and providing care within the space. I started to think a lot about the ambiguity of the roles, particularly amongst early career nurses, thinking a lot more about the hidden curriculum that shapes our competence and how nurses navigate resource-constrained systems and in places where most of these are not taught or learned, but somehow we manage to find and figure a way out within our systems. And so these early thinking and early studies taught me that competence is sort of something that is closer to relational. It is something that is shaped by supervision. It's something shaped by the workload, teamwork, and the system itself. And as I graduated from this early career phase within the district clinical space, I moved countries. And from this part, I moved on to a different country called Lesotho. So Lesotho is a small developing country within Africa. So it's located within Southern Africa. The country has a very high disease burden, very colliding disease burden, high maternal mortalities, issues around communicable diseases, non-communicable diseases, and even violence. And when it comes to resources, Lesotho does not have a lot of resources. But what happened with my career is that I found myself now working within a nursing training institution, or at that time called a rural nursing college. And what we were working on within that rural nursing college were issues where the way in which the training was done was sort of similar to what we saw in some of the colleges in Southern Africa, where the curriculum was still labeled as outdated. It was very hospital-centric. And I mean, from the first time the students come in to study nursing, they're already put in the bedside and they're starting from vital signs, patient care, and they're moving through the specialized units within the hospital. And at the same time, while I was starting my career within this space, the country was undergoing major educational reforms. There was a need for us to reimagine what does education look like? What are we doing in terms of our practitioners? And do our nurses actually meet the needs of the people that we work with? And so that sort of started to become an interesting engine of where I was working from. And I just wanted to mention that in as much as we were driving this hospital-centric kind of educational process, we were settling in a country where 75% of the people were living in rural areas. And by the time we get our students to go and work, they struggle to adapt their hospital approach to nursing to the practical realities of rural care, of community care, which is outside the hospital space. So we started to ask ourselves key questions. And part of the key questions that informed part of the research that we started engaging in were what are the competencies that are necessary for nurses that live in such a mountainous country where over 75% of the population is rural that are needed within an education space. Some of the questions included how should nursing education mirror what we understood as the primary healthcare model, where care actually starts from the households, traverses through communities, and then later reaches the hospitals? How do we reimagine nursing education that it actually aligns with this type of model, such that we're able to empower our nurses, that they're able to then provide the necessary healthcare? How do we shift the theory-heavy, nursing program to a program that is practice-based with intense community immersion? So as we started to have these type of questions and reflections, we then started to work on redesigning our curricula into competency-based programs. And these competency-based programs were more community-rooted and not rooted within hospital-based. Not that we cancel the hospitals, but we try to focus this thinking towards community orientation. And the way we try to position our work was then to get our first-year students that are already coming from the very communities to return to the communities and not immediately go to hospitals. Work with the communities to conduct community-side assessments, co-design communities with households and document these outcomes. I mean, co-design interventions with these households, and then document the outcomes of such interventions within the communities. And I mean, the type of projects that the students were engaged with the communities were fascinating, from issues around food security to issues of hygiene to issues of prevention. I mean, there was quite a good spectrum of what the students and the communities collaboratively started to work with in terms of improving health outcomes. So we started to even shift the way assessment within the program looked like, that we moved our assessments from just memorization and writing, final end of year examinations, to more development of evidence and portfolios of evidence to mirror exactly what competency-based education literature suggests, linked to authentic learning. So this is part of the work that shaped some of my doctoral research around sustaining curricular innovations, both within the nursing program and also within midwifery education. And one of the big drivers and issues around sustaining was trying to look at what are the key variables and how do these variables interplay to make sure that the country with limited resources and limited income, if we could put it like that, could sustain such curricular innovations that could build on the competence of graduates. And one of the key findings that echoed throughout these studies was that curriculum reforms will definitely collapse if the faculty or the educators were not supported, are not empowered, or are not equipped to implement that. And so for me, faculty development, which was my next layer of interesting research, became a real engine for change. As I engaged with the experience in Lesotho, my scholarship around research also started to expand to interweave the three key issues around faculty development, issues of community-based learning, issues of competency assessment. One of the issues that we started to build on as collaborative researchers was looking at how to engage educators, from transitioning from their approaches that they've traditionally been engaged in over time to then moving them to become facilitators of learning. How do we improve and equip educators around assessment literacy? How do we work around strengthening simulation? And how do we support them in the debriefing processes to shape how students develop issues like critical reasoning and clinical judgment? In addition, we also try to document how does community immersion of the students within the communities promote social accountability or even shift the students' understanding of the health systems. And what we found was actually quite impressive in how students started to see things quite differently and how they could link their work within the community as being more closer to their own health systems because of familiarity, knowing the people on the ground, that by the time they get to the hospitals, they know exactly who's coming in and what are the key issues that they're faced with. We also explored the issues of assessment and how do we actually translate assessment strategies, approaches that are often, coming from the global north to a global south space where, again, there's an issue of resource availability, there's an issue of translating literacy and strengthening capabilities for assessment. So over time, we started to see that the central truth that emerged from all this work is us to understand that as educators or as nursing, we need to refocus this conversation, not only looking at it as just a research exercise and getting the data out or getting curriculum and getting that out, but to think very strongly on how do we empower the very same educators that are supposed to translate these documents, that are supposed to translate these interventions into practice. And therefore came that metaphor around lighting another candle, that not being particularly a poetic metaphor, but being a pedagogical strategy and a system requirement. But we also understood that to strengthen and the so-called build capacity amongst faculty, which is often romanticized, but what we're finding is that it's something that definitely needs a lot of time. It needs a lot of resources. We need institutional support. We need to also think about recognition and also political commitment, both within the institution and above the institution. Otherwise, without this, we risk expecting educators to deliver modern curricula or to deliver curricula that is changed or to align with global standards and so forth, while they're working in conditions that are not supportive of change. And often we then come 5 years later to evaluate this process, and then we say, no, this didn't work, the curriculum change didn't work, yet at the same time, we did not provide resources to support these educators in transition. So this again builds another exciting element of the research that we have been engaged in, again towards strengthening the educator capacity in developing these curricular changes, and at the same time also looking at the early career nurses that we're also coming in. And across my journey, and as an example of an early career nurse, we often see that description, of the words, resilient. We have to be resilient. We're expected to be resilient. There should be resilience of the students. When things are tough, people are expected to be resilient. But we know that resilience is not neutral. Resilience can come as a way of sometimes normalizing structural deficits. Sometimes there's romanticization of suffering. And sometimes we're also seeing that we individualize what could be systemic problems. So with my research, and that of scholars around structural competence, what it has taught me is that we cannot build strong practitioners on the expectation of personal heroism, being this one person to change everything else. We need to remember that the systems must also be reformed to reduce avoidable burdens and also protect the learning environment. So when we think about strengthening or transforming curricula, strengthening educators, we shouldn't only be thinking is, yes, it should be just this one intervention, this one workshop, and everything should work. And if it doesn't work, we come back to say, but why is this not working? Without us also looking at the multi-layers, the multi-complexities that influence this adoption of change, this adoption of innovation, and also transforming our health systems. So the question becomes, how then do we support others without allowing the system to offload its failures onto them? And that too becomes the work of practice development. And again, another additional layer of how we can strengthen educators and strengthen systems at the same time. My research also built on this work landed in the space of interprofessional collaboration. And what this whole process has taught me, and again, to build on the work, was that there is no single profession that can deliver care that is safe, equitable, and effective on their own. And we've seen the literature supporting this all the time, be it at community level. You cannot have this single profession do these interventions on their own. We understand that communities, humans are multi-complex systems, multi-complex individuals that require not only a single profession, but everybody else to work on. Either it's a systems issue, it's a personal issue, and looking at humans as a biopsychosocial spiritual being. And so the nurses cannot do it on their own. They need everybody else to come through within that interprofessional space. And we know the literature keeps on chiming on the same issues. WHO has published works around IPE. Frank has done the same thing. Reeves have done the same thing. And it is clear that collaboration will depend not only on just goodwill and having us wanting to do it, but we want to think more closely around shared governance. How do we bring the professions to share leadership and governance? How do we start the conversation of developing joint curricula amongst these professions? And how do we dream about integrated learning spaces where we're not only dreaming of just attaching the nursing students to the community, but getting the nursing students, the social working students, the medical students, the physiotherapy students, all of these that are working within the very same community? How do we also become clear around scopes of practice and our boundaries within that, and also building on accountability mechanisms? So one of the biggest challenges we face, particularly in Africa, and I'm sure it applies across the world, that we still are often hindered in developing our interprofessional education and collaborative practice due to these siloed funding streams, We also find competition happening between our regulatory councils. We also know that there are these entrenched hierarchies where all of a sudden, the doctors are at the top, the nurses are at the bottom, and everybody else is trying to fit themselves in between. We also do understand some issues around culture that may come in that separate men from women and others be coming in from power. We still see issues around race that also comes in, the discrimination that comes through sexuality, that again also affects how we think about collaboration and what collaboration actually means. And we still do see processes in which the way we plan our teaching, our curriculum structures are fragmented. So this is why my own scholarship over the years has started to increasingly look at what does it mean to talk about interprofessional competency framework? What does it mean to say team-based learning, collaborative practice models within curriculum transformation, and again, within a space like the one we find in Africa. And it's true that we cannot build candles in isolation. Candles must be arranged in a room, not to burn alone, but also burn with others, and that makes the room brighter. My next chapter of my life after the interprofessional space, I then started to work within the WHO. And the WHO for the African region serves about 47 countries, of which a majority of these countries, believe it or not, are actually French speaking. And that really got an exciting part of how we bring this together. And part of the issues that is strengthening the education of the world health workforce purely in the space that this is building towards what they're calling the African Health Professions Education Initiative, which is sort of how do we strengthen education and how do we build from education into standards for education, and then from standards for education, how do we eventually look at the reciprocal recognition of qualifications. So in 2022, the WHO published the Global Competence and Outcomes Framework for Universal Health Coverage. So this is a set of competences built in a brilliant competency framework that is trying to look at what are the necessary competences that are needed across the health workforce, particularly in pre-service and in specialist education, that would be necessary for us to attain universal health coverage. And so that particular framework became an interesting starting point for the WHO to think a lot more about how do we distill this within the African space. And then in 2024, we embarked on that initiative around the African Health Professions Education Initiative, with the starting point being around developing what we're calling African Prototype Curriculum. And this process was quite a collaborative process with more than 300 stakeholders across Africa, who was aiming at how do we work around developing 10 curricula for selected occupations, and the region's first outcomes framework, competency framework as well. So the idea was actually that we do not want to have these as sort of prescriptive curriculum, but become a benchmark in which countries and institutions that are trying to move away from, our traditional hospital-based, content-driven type of curricula into some competence-based approach could sort of benchmark and start that initiative. So apparently last week, the 24th of November, we successfully completed and launched 10 Africa Prototype Competence-Based Curricula and the first outcomes framework for graduates within Africa. And just like I said, that the idea is that these are not prescriptive, but are based on some regional consensus on some of the key challenges that we're facing, and to see what is actually possible. And we want the member states and the countries to be able to see what is possible in their setting, what is missing, and what must be conceptualized. And so my research within curriculum design, community-based learning, faculty development, and interprofessional practice sort of came in to shape the methodologies that we used in the development of this work, from backward design to outcomes mapping, the authentic assessment in context responsive integration. So the bigger piece of this was to actually develop documents that become relevant for our case within Africa, for Africa, by Africans. But we all are also, we remain conscious and aware, because this is what, again, research is also informing us, that even if we do have good curricula, good documents, they cannot compensate for poor clinical environments. Competence-based education, which is what WHO is pushing for, also requires investment, not just the excitement and enthusiasm. We need a lot of investment, and this investment transcends from developing the very same people that will be expected to translate these documents into practice, to the communities where the students are going to be working in, and also the development of the students to actually know what would be expected of them. And again, we know that if these become adopted without any adaptation, we actually risk a massive replication and not an educational reform. And so we've been very clear that at WHO, we want these to be co-created and not a prescription. And so in linking with that candles and light metaphor, that yes, a candle can light others, but only if there is oxygen in the room. So just to build on the next piece of work is just to also add on to say that I think eventually the research over the years has really moved in trying to link the practical realities that we face on a daily basis, and how do we then prepare the students that they're able to meet those practical realities. And not only the students, then it builds on the faculty that are supposed to implement this, and it builds on the communities that we are supposed to work. But then it also positions yourself, myself, as somebody who then becomes that conduit for supporting others. So that makes the journey merely, not merely just a personal journey, but something which is a bit ethical, and on the other side, a bit political. So when we embed students in communities, we also start to carry some obligations, right? Are communities true partners, or are they unpaid teaching resources? Do students bring value, or are they just there to just extract experiences from communities? And how do we ensure that our community-based education benefits the community and is not just a curricular tick box? So even as much as we embed these outcomes across the curricula, we just don't want this to become, oh yes, they are meeting the requirements of only the university or the college, but this should have a direct benefit on the community in which we are getting more students placed in. And Lisbeth Hockey insisted that nursing must be relational, it must be collaborative, bridging the gap between institutional care and the realities of people's lives. And I would want to add on to say, my research also echoes this a bit. We need to support that support that must be reciprocal. There should be support that's negotiated, but also support that's respectful of the power dynamics. So by being a conduit, it means we are able to advance others through ourselves. We need to be in a position where we think about challenging inequities, about challenging poor learning environments, about challenging unsafe staffing, and also some of these colonial legacies that we find ourselves in. And so this is not gentle work. It has not been gentle work, but again, it is necessary if we are to light each other and pull each other through. And what it has meant to be a researcher in Africa is something that has quite been insightful and very interesting, because it's not just only about symbolism, that we're just getting all the papers coming out from Africa, but the biggest part is about how do we actually investigate things that matter, and not only matter for promotion and just the number of publications, but matter for the communities that we serve, matter for our colleagues, issues that matter for our students. And with time, we started to see some signal and growth, which brings in about some new models, some new questions, and some new possibilities for practice development. And I must say, the African prototype curricula, the framework, we've worked now on some emerging research around AI and VR, but the biggest and most exciting part was how we see all of these technical stuff translating to the community, translating to the students that are learning, and then strengthening the issues around collaborative practice, recipient of knowledge, but it's a space where we're trying to see some generation separation of knowledge, shaping global conversations, and again, loses nothing by lighting another candle. But again, about this, some candles are cracked, some are bent at both ends, some sit in the winds that could even extinguish the strongest flame. But my invitation today in the spirit of Lisbeth Hockey is twofold. Number one, that we support others. Light the candle next to you, whether it's a junior colleague, whether it's an early career educator, whether it's a community partner, students, researchers. Everybody needs that space to grow. And perhaps you can be the person that builds on their career. You can be the person that switches on their candle. Again, let's also think about fixing the systems. Challenge the structures that exhaust candles faster than we can light them. Advocate for conditions that allow competence, advocate for compassion, and advocate for collaboration that we flourish, and always thinking about the end in mind. Who is our beneficiary for all these research areas? Every one of us has the power and responsibility to create these resources, these environments that we can all shine, not as an individual, not just only as nursing, but as all health workers that provide healthcare, whether it's in education, whether it's in practice or within the candle, sustainably and intentionally, then we can perhaps surely honor Lisbeth Hockey, not only in our words, but also in our action. I want to pause here and say thank you very much for the opportunity to share a journey of research, a journey of thought, and a journey grounded in attempting to transform the communities where our students learn, where we practice, and where our health starts and where health begins. Thank you very much, and over to you, Faith.
Thank you so much, Professor Nyoni, for your insightful lecture. I believe everyone is super excited about learning about your insights, your experiences, but also the technical aspects that have enabled you to eventually be another candle that is lighting others in this world of community research nursing, but also beyond just nursing to make it more interprofessional. With that said, we are now going to move into the Q&A session, and I would invite Professor Nyoni and Professor Sally to be part of the panel, and you can turn on your videos as we address these questions from the participants. And the first one that we have is from Barbara Stilwell. Resilience is such an important issue for health services. Your observations on system resilience are key. There is not enough focus on developing robust systems, but resilient people are part of resilient systems. I think it is both and not either or. I would be interested in your comments on that and on ways of fostering resilience in nurses. Over to you, Champion.
Thank you very much. Yes, you can hear me. I totally agree with the comment, and I think it's really not an either or. I think the easiest low-lying fruit is always to say that people should be resilient, and we expect resilience from the people, while at the same time we forget to put the system into account, because in as much as you practice, you also should be practicing within a safe environment. We are pushing for better working conditions, we're pushing for better systems, and I think as we push into this space, we should also hold the system into account. Am I being enabled to flourish as a practitioner? Because I deal with these issues every day. So I totally agree with the comment that I think it's not an either or, but we need to push for system resilience. And we do advocate, yes, for our strengthening and our, but we also need to stand up and now say, let's talk about the systems and where are the loopholes. And the reason we are not getting to where we're supposed to be is because the systems are letting us down. And one of the biggest issues, I think, from a standpoint is, again, how do we empower ourselves that, given the opportunity to sit around the table, we're able to speak in a language that those that have power to change the systems hear us. because sometimes we get lost in translation and then we speak in our terms, and then we speak, for example, to the Minister of Health, and I'm telling him about interprofessional collaboration. That means nothing to him. He has no idea what I'm talking about. But how do we twist our language that we also become politically savvy, that we're able to argue about the systems in a manner that he gets what we're talking about, in a language that he understands from a political standpoint, that also builds this argument that we're talking about. So I totally agree with the colleague that definitely it's not just one-sided, it has to be both ends. It's only just for practitioners, it's the low-lying fruit, and everyone is easy to say we should be resilient without pointing at the system. Yeah.
Yeah. And I also think among nurses and midwives, it's key for us to develop that advocacy skill to eventually push and foster resilient systems that work and all that. And over to you, Sally. Would you want to contribute to the discussion?
Yeah, I mean, I think just one further, I mean, I totally agree with everything that Champion has just shared with us. It's incredibly important to have this systems resilience that is going to be there to kind of hold and support the professional resilience. But I wonder whether part of this and where we could, you know, advocate even more is by bringing the public with us, you know, because I think the voice often at a political level gets lost in terms of the what the public really need and want from professional community nursing. And if we can bring more of that voice into the system, into the politics, you know, as you say, Naomi, that the ministers often don't really hear the language we're speaking, but sometimes they do hear the language of people and experiences. And if we can bring that more closely to the table, I think in a shared way, that can be empowering for nurses, but it can also help to build that system resilience because different voices are being heard.
Sure. Thank you so much. We will move to the next question, and this is addressed to you, Dr. Nyoni, but me and Sally are here to help spice it up in case you need any help. Dr. Nyoni, how do we facilitate collaboration considering the research landscape in Lesotho or low and middle income countries?
That's a very good question. And my experience has been nothing but interesting in getting that collaboration going on. Backward thinking, first and foremost, the outcomes of collaboration have been great. But what we found was our interesting starting point was getting people on the table, and not getting people on the table to, what I would say, to get them to do what we want. That wasn't the point. But getting people on the table to literally focus on what are the challenges that we are facing. And the challenges we were facing were not necessarily, oh no, we are here to moan about what nursing is going through and we need your help. The issue was more like eventually what happens to the patient. We are struggling with this, we need that. And then we just started it as a casual dialogue in our space, in that build up a lot of momentum. One of the key issues that we then found was how do we start the structured discussions on what are the differences and what are the similarities in things that we do. We started to learn that sometimes more than half of the times people don't even know what nurses do. Nurses didn't even know what the physio, the OT do. Even the doctors at some stage, they don't even know what this one does and what that one does. And that became our starting point of conversation. And with that sharing around role clarification and getting to know each other, it started as an afternoon tea that became a regular discussion, and that started growing. We started to see how we can play a role in making our work a bit better for each other, reducing this duplication of things. And, so it started to start to streamline the process a bit more. But the bigger picture was this is not Champion doing it for nursing, or this is not Dr. Nawaji doing it for doctors, but we're just saying, we've got a problem with our patients and how do we make this work better? So I think it was just building on some strategic thinking being casual about it, allowing people freedom of speech and discussion, and then that built on the process. And one of the few experiences that we started getting was, I feel my load is a bit lighter because I now know and trust that somebody on the other side is going to deal with this part of the work. We started to dream about, so how do we start to even think about an interprofessional round, a collaborative round, where we all do the round together? Because that wasn't part of the practice. And it's always starting in with these questions. Can we do it together? Can we have the OT come through? And that casual type of friendship also started to build in. But the biggest thing we learned was issue of trust. That trust needed to be built in from beginning, that you are able to trust each other as professionals, you are able to be very clear about your strengths and also your limitations and your challenges. And with that, it started to build. But I just want to say that it's a thing that builds over time, but it means consistent engagement and also strategic discussions towards collaboration. It will definitely not happen overnight. But again, it's just needing to look at it from that strategic angle. But it was such an interesting experience, and you really realize that it's not that we don't have resources, and I think we do have resources, but maybe how do we position our resources better? And we could if we work collaboratively.
All right. Thank you so much. We'll move to the next question for purpose of time. This is from someone called Gina. Thank you for sharing your deep knowledge and expertise. It was interesting to note your mentioned resistance to degree level education for nurses. Please share your views on recent moves to deprofessionalize nursing and plans to withdraw student funding for support for undergraduate nursing programs. Whilst this is originating in one national state, do you have concerns that a global movement with, I think she meant with this issue, will ensue? Yeah.
I struggle to hear you, Faith. Deprofessionals are only, please say that again. I'm sorry.
All right, so this question is from Gina. I don't know if you're hearing me well.
Yes,
Are you
I
able
can
to
now.
hear me? Yeah. So the question is, thank you for sharing your deep knowledge and expertise. It was interesting to note you mentioned resistance to degree level education for nurses. Please share your views on recent moves to deprofessionalize nursing and plans to withdraw student funding for support for undergraduate nursing programs. Whilst this is originating in one national state, do you have concerns that a global movement with this could grow and all that, or aspects in regards to this issue? I'll begin a bit before I put you on a hotspot. I started off as a nurse and midwifery practitioner, and I trained back home in Uganda. I'm one of those as well that faced a lot of resistance on people not being aware of what it is that we should do in the healthcare system. And we eventually now devised ways of existing and understanding that we can practice nursing through research, administration, training, leadership, etc. But with this new move that is being mentioned, how do we ensure we show relevance that actually nurses are the biggest number of health workforce globally, and we are the ones who spend most of the time with the patients, both in the hospital and in the communities, and we are the best people to produce evidence-based practice and all that. So over to you, Champion and Sally, to weigh in on this issue.
Not a problem. I think that if I understand the context of the question, and I think this is in relation to what's happening in the United States, when we talk about deprofessionalizing nursing, which hasn't touched base in parts of the world, Africa, for example. But the reality also is that when we started to think about and move towards professionalization of nursing in Africa, and that's like 20, 30 years ago, we started to see mushrooming of university degree nurses into practice. There was this massive misconception, massive resistance And usually the people that were making the decisions about nursing were not nurses. So they would not understand what the nurse is supposed to do, because for them, this is just an extra pair of hands in the hospital. Why should this person get a degree, a master's degree for that matter, and so forth? And I think the models in the US have been quite instrumental in shaping the thinking around professionalization of nursing across the globe. I think US has been a champion in terms of advanced practice nursing, the interpretation of master's degree in nursing, and so forth. And it is really quite scary to hear about this, deprofessionalizing of nursing. It feels for me like we are taking, 50 steps back for the profession, which is something that I think it's like you mentioned, the biggest number of health professionals. I think they're quite necessary. In the US has been, the forerunner in terms of the structure, the thinking around professionalization of nursing. And I think it could be an opportune moment as well to look at how do we rethink our advocacy approaches, which could be a low-lying fruit. But I think it really needs to higher up in the political space. When do we start to challenge this? Because this is unprecedented, to actually think of all the health professionals, why particularly nursing. And we have evidence of better outcomes from nurses that have got higher qualifications on patients. And the dream for most of our countries is actually to upgrade nurses, to create opportunities for nurses to grow and to professionalize the field, which means we just don't want to be an extra pair of hands or people that are coming in to do this. We want to strengthen our research, our scholarship, publications, our intervention, our science, and that cannot happen if we're not within the professional space. And if we're working also in an intercollaborative space, we also need to stand tall like all the other professions in the space. Otherwise, that also affects the relationships between our interprofessional team. So my take about it is that it really feels like we've moved a step back instead of moving forward. And America has been quite a front runner in the professionalization of nursing. And this is, we hope that something would come through for us to reimagine this particular space.
Sure. Thank you. Sally, would you want to weigh in?
Yeah, I mean, just to add what I can, I think it does feel retrograde and we can't allow it to happen. I think we have to come together, all of us in our various organizations, to really strongly resist what appears to be happening in the US right now. As you say, Champion, I can't remember the exact date, but I think one of the first nursing degrees started in the United States around about 1912 or something like that. It has led the way. We have all developed in different ways in our own countries to really professionalize and develop nursing in a way that is now respected and regarded amongst our colleagues and our politicians as, a leading healthcare requirement to foster and improve patient outcomes in different ways across the globe. And as I mentioned earlier, the public also have a view on how nurses contribute to their healthcare and the importance of nursing to their healthcare. And I think increasingly in the community, people are recognizing that, they don't want to be in hospital. We have interventions and technologies and ways of working relationally with people in their own homes, in their own communities, which ultimately also improve outcomes enormously. And we have plenty of evidence and research to show that. So let's not let this happen across the world. It's a terrible mistake in the US, and we have to come together and really become very proactive to ensure that this is not a global movement.
Yeah. Yeah, thank you so much. And just to give a remark about that, we are all striving to see that we advance interprofessional collaborative practice in all areas of healthcare. But one of the key things to advance this is professional identity. So when we deprofessionalize one of the biggest workforce that is key in maintaining holistic care, both in hospital or communities and all that, it then will undermine the efforts made to advance that, but also create a question of how do we then integrate nursing into interprofessional teamwork and team building, etc. So with that, let's move on to the next question. It's from someone called I'm sorry if I'm not pronouncing your name right. How do faculty react to the need for a community-based education? And how do you support them to change their focus to community away from institutions? Sally, would you want to start off with that?
I think I'll let Champion respond first because he's done so much work and research of his own in this field, and I can add something perhaps afterwards.
Yeah.
From our experience, the starting point is not always easy. And often this is what is labeled as resistance to change. And it's always that initial process of, yeah, so what are you saying that the students are not going to the hospitals on day one? Are you saying the students are not able to measure temperature in their first year? Are you saying this is going to happen? And that initial reaction, is I found it quite interesting because it reflected a lot of some of the ingrained approaches and models that we've done over the years. I mean, we've perfected them. In the space that we now think about, yeah, but maybe let's rethink about this, in a different way. We even had to have, negotiations over and over again with faculty to say that the students are actually going to the community, not to go household by household measuring temperatures, but they're going there to actually look at a community-wide assessment, a community-wide diagnosis. So
Um, all right. As our champion comes in, we can continue as he gets his signal clear. Champion, we kind of lost you. I'm not so sure if you're hearing us now. But what I wanted to also add, I'm one of the products of having gone through a community-based
about
curriculum.
it, but the big
Sure.
process is understanding that this is not coming from the resistance.
Okay. So as he gets back, yeah, I just wanted to weigh in. I've been part of the students that went through a community-based curriculum, but also that was coupled with PBL, which is problem-based learning. But in addition to that, I've been part of those that have enabled various schools across Africa to adapt community-based learning and things like that. So with that in mind, what is it that I saw working and all that? Creating community-based module in phasic ways helped in such a way that it was spread across different years of training, but also making it interprofessional so that people don't feel that the faculty load is only on one profession to run this program and all that. That helped a lot. There was need for proper community sensitization before the whole aspect of student placements happened, so that there is enough support through the community leadership, but also openness of the community to receive us in their various homes as we did our home visits and etc. What really worked for the different institutions that I've seen that have been able to support in developing community-based curriculum and program and all that is ability to have a curriculum for what it is that we want to advance as we implement this community-based education. Beyond the curriculum, what are our learning outcomes? What are our learning objectives? And how do we evaluate the outcomes to ensure that at the end of the day, there is meaningful engagement for the students and learning, but also there is meaningful ability for the people to learn from the community, to learn from the students, but the students to learn from the community, but also the faculty to have an opportunity to learn from the community as they advance. In this case, it was not all about the teachers doing the teaching. It was about learning that involved the pyramid of the student, the community, and the faculty. Champion, we lost you as we were going through that question, but no worries, we can move on to the next one, unless Sally, you want to weigh in as well?
Just one additional comment. I think, in terms of faculty, from my own experience, it's also really developing and recognizing leadership in faculty, and that inspirational leadership that people have brought to existing and previous programs, and how we can learn from that. My own experience, as with others here, was, I did nothing in hospitals in my first year or my first term. I went out into the community and worked with families to find out, what it meant to be part of that community, what the context of their lives was. And that happened because we had a hugely inspirational leader for our program who wrote and taught others, but also learnt, as you say, herself about what it meant to be in the community. So I would say that, leadership is something that we need to recognise, build on, and ensure in the way that we develop faculty.
Yeah, yeah. All right. Thank you. So the next question is from someone called Ronald Nachipo. I apologize if I'm not pronouncing your name right. Interprofessional collaboration in healthcare settings remains a significant challenge across Africa, often resulting in patients receiving substandard care. Contributing factors include delayed communication between departments, blurred professional boundaries, and power imbalances, particularly where doctors dominate decision-making. Did you consider highlighting strategies for strengthening interprofessional collaboration, both during training and in clinical practice? I think Champion has dropped off. Sally, would you want to give it a shot? I can give it a shot as well.
I'll let you take that one.
Sure, sure. So thank you so much for this question. In fact, one of my PhD objectives was about creating a framework for interprofessional education and collaborative practice within the international learning environment across Africa. So what are those strategies that I developed, and all my papers are published, and frameworks that can help different institutions to adopt this in the clinical aspects or in the classroom teaching, simulation labs, and all that are all there. And I went ahead to develop a framework that can be adopted by different countries across Africa. But one thing I want to highlight is that this has to be done in stages. It can't all be done at once. But also, the whole curriculum can't be turned to be interprofessional because it will be so much resource intensive. But what can be done that is practical within our settings here in Africa and probably globally is to understand what nodes can be used within the curriculum of each year to advance interprofessional education. There are various competencies for interprofessional education and collaborative practice. And then the aspect is up to that institution or faculty to choose what competencies can we advance in year one? What competencies can we advance in year two? What competencies can we advance in year 3 and 4, etc.? The aspects of only thinking that interprofessional education can be only advanced through a formal curriculum remains questionable because institutions run through an aspect of culture. How we do stuff in any institution is very key. So if we can develop an aspect of an interprofessional culture in how we do things, if it is in social environment, how do we ensure that is done? If it is in the formal classroom environment, how do we ensure that is done? Students also always mimic what they see. And so it means that it goes back to us as faculty in the different professions and all that to think, how best can I be a good example of interprofessional collaborative practice? I won't take you into the details of the approaches that have been developed, but feel free to just put my name in Google Scholar. You see a couple of papers that have practical ways that students and faculty can use to adapt interprofessional collaborative practice, both in training and clinical practice. So, Champion, as you were off, we were trying to address the question on interprofessional collaboration and how it can be adopted during training and in clinical practice. And to throw in a joke, Champion was my opponent during my PhD defense. And it was quite interesting to learn from his questions, but also be smart to answer all his questions and all that. So please feel free to always read the work. It's there, and aspects on how to do it here in Africa have also been developed. So with that said, I'm not so sure if we have any more questions. I think the other is a comment. Is there a group or something else that unites members? Yes, the Global Research Nurses, which I'm part of, as well as the ICCHNR, are open to membership, individual memberships from nurses, and it's free to sign up to the Global Research Nurses, and then you can be able to access the various materials. The ICCHNR also has its own membership aspects that you need to follow to be part. And I was once a scholar of the ICCHNR, and I'm happy to be part of this lecture today so that we can all share in terms of advancing community nursing research. So that's it, Hadija, in regards to your comment. So I think we have one more question as we round up. To Faith, I think, has the community-based curriculum been incorporated into the nursing curriculum in Uganda, either as part of the general nursing or as an undergraduate program? Yeah, I'll speak to that. And yes, examples exist in Makerere and in Mbarara University. Yes, community-based curriculum is part of the undergraduate curriculum, which I was part of in reviewing. In terms of if it has been taken up with the different levels of nursing, as you know, here in our country, we have diploma and certificate nursing. I'm not so sure about that. Professor Nyoni, over to you. You had your hand up.
I just wanted to add that point, that we are still, so when we speak interprofessional education, it's a bit easier for us that are sitting at universities, because we have the degreed nurses that work with other degreed students. But the majority of our nursing workforce in Africa comes from nursing colleges. And these nursing colleges are often affiliated to a hospital or attached to a hospital, learning away from the other health profession students. And they're often missing in our interprofessional education endeavors because often it's university driven. And I think the biggest challenge we have is that how do we make sure that we design inclusive interprofessional collaborative mechanisms that will allow even the students that are training at a diploma level of nursing to be part of that type of conversation. In South Africa, where I did most of my research, we found that 80% of the nursing workforce was actually diploma trained. So they were coming from the nursing colleges, while only 20% of the nurses are at universities. So when we did IPE interventions and community-based education, we were looking at the university trained, but again, leaving out the college. We tried to work on what we called AfriVibe, the African virtual interprofessional education mechanism, where it was online and we tried to bring colleges on board. But we do know, the strengths and limitations to online learning, that sometimes you really need practical hands-on or simulation, that kind of things, and there were limitations in that space. But I think that next layer, like the question you're being asked, Faith, is how do we strengthen that collaboration, that it doesn't only look like, this is only for the university degreed nurses, but it includes all the nurses across the board because they have a role to play. And I mean, the bigger picture is often about the patient and community outcomes. That's all I wanted to add.
Yeah, and that's true. And that remains a gap and a hard one to hustle through. Yeah, yeah. Professor Sally, did you want to weigh in?
I wonder whether there's also more that we need to think about in terms of pathways into education and, where this really begins for nursing. So, I think we've seen in the UK something of a downturn in, young people being even interested in coming into nursing. And there seems to have been, perhaps a bit of a cultural kind of shift away from this kind of profession. I don't think we fully understand why, but I think we've got some indications around the way in which societies are moving more, into more kind of away from vocational learning and training into more what they might see as more economically productive areas of work. So perhaps one of the things we need to think about is both how we encourage young people to come into nursing in the first place, and then what kind of pathways can be offered that will ensure that, for example, colleges and universities work together to offer ways in which nurses can learn, which are both enabling in terms of the cost, because obviously cost is important to students, but also the kind of infrastructure and ways in which they can learn, as you say, maybe through distance learning, but by ensuring that they're actually able to attend the communities that they're working in or the universities that they need to get to. Often there are challenges there, I think, just being able to move around countries and to do things in different ways. So I think there's quite a few things that we could look at in terms of the pathway to learning.
Sure. All right. Thank you so much, Professor Sally and Professor Champion in absentia. I think we've had a very engaging talk with the audience, but also for the key insights from Champion as the theme stated, research that transforms communities. And I think it was very evident through his experience and work and how his research has eventually impacted communities and global and regional standards in terms of community nursing and addressing the teaching gaps and things like that. So with that, we would like to move to the closing remarks for this event. We have an evaluation poll to enable us learn from you, the audience, how this session has been. And this is going to be projected soon, right now. So please feel free to answer these questions so that we can get an idea of how this session has been to you. Feel free to vote or give your responses in the poll. It's still up. It will be closing in the next 1 minute. All right, so these are the responses, and I think this is a good shot. It encourages us to continue really hosting such events because there is a good impact or immediate outcome. So we'll be able to take note of this feedback and do better or ensure that we show continuability to those that support us for this work to be able to be advanced. With that said, I would like to move on to some TGHN updates and notices for you to pay attention to. So we also have a feedback survey that is more detailed about the webinar. This is more of a poll to give us an immediate feedback. Then thousands of global health professionals like you who are part of this event today take part in free webinars and workshops hosted by the TGHN network. So your support keeps these sessions free for researchers and health workers everywhere and helping them conduct studies even in times of crisis. So if you feel you would be happy to donate in whatever way, we'll be able to project the link that you can use for the donation, which is being projected here. Feel free to scan the QR code for the feedback survey to pop up and the donation code to show up. With that said, I would like to end the session and say thank you very much for everyone who has attended. And we look forward to more meaningful engagement. And yeah, Sally, do you have any closing remarks?
Thank you, Faith. I think just on behalf of ICCHNR, I'd firstly like to thank the Global Health Network and particularly Faith and your team for collaborating with us for this Lisbeth Hockey Lecture. I think it has been wonderful the way that it's come together and the contributions that everybody here has made. So thank you to the Global Health Network and to everybody who's joined us. And particular thanks, of course, to our speaker, to Dr. Champion Nyoni, I think, for a very inspirational and engaging lecture this afternoon. I'm delighted to see the evaluation and how much people have taken from it. But thank you. I'm sorry that Champion has had to leave us, but I hope he will know how much we've appreciated his time today and engaging with him. Thank you.
All right. Thank you, everyone, and have a good day wherever you are. Yeah.